right. Well, good afternoon. Sorry about that. So again, my name is Kristen Bagno. As she mentioned, I'm a head and neck radiologist at Emory, and this is my second case review live session, and I'm going to hopefully go over some interesting head and neck cases today. I have nothing to disclose, and hopefully my goal for today is to review as many interesting and high yield head and neck cases, questions, and companion cases as possible with you today. I'm going to help you become familiar with some of the differentials and varied imaging appearance of other lesions in those locations. And I have a total of 6 cases, but lots of companion cases to go through. So hopefully we'll get through all of them. So case number 1. So first we start with a 48-year-old with vision changes. And I'm going to pull up the Ambra system here, hopefully. Here we go. So case number 1. Hopefully everyone can see this. So we have MRI images. This is a post-contrast. You can see the contrast enhancing in the inside the vessels, post-contrast images through the level of the orbits. And you can see what looks like enhancement throughout the entirety of the left orbit. I'm going to scroll up and down. And you can see it kind of looks like the entire orbit is enhancing both the intraconal and extraconal fat on these fat-saturated post-contrast images. Here we have a T2 fat sat image, and similarly on the T2 weighted images, the areas that we're enhancing, again, looks like there's sort of a transspatial infiltrative T2 hyperintense enhancing mass. However, when you go to the T1 weighted images, you can see there's really no abnormal soft tissue here in the orbit. It looks pretty uniform. The fat, extraocular muscles, the optic nerve, the globe, all looks pretty normal in appearance. And then there were some coronal images, and on here you can see this sort of alternating bands of high signal and low signal and distortion of the soft tissues in the coronal plane on these T1 weighted images. That is compatible with something metallic susceptibility. So now I'm going to go back to the PowerPoint, and we're going to kind of review some of the salient imaging findings here. Oops. So again, we have the T1 post-contrast images, what looks like apparent enhancement throughout the left orbit, T2 hyperintensity throughout the orbit, appears as if there's sort of diffuse abnormality, but there's no abnormal soft tissue on the T1 weighted pre-contrast images, and we can see this dental amalgam artifact on the coronal T1 weighted fat saturated post-contrast images. See how there's fat saturation. And so here's my first poll question. What is the diagnosis in this case? So A, is it incomplete fat suppression artifact? B, is it orbital lymphoma? C, orbital cellulitis? D, orbital pseudotumor or idiopathic orbital inflammation? Or E, orbital metastasis? So if you get a chance, go ahead and try and vote on what you think is the most likely diagnosis in this case. Okay, let's go ahead and close the poll and see what the response is. Okay, and most of you correctly noted that it's incomplete fat suppression artifact. There are a few, or one person is worried that it might be orbital pseudotumor. So let's talk about this a little bit. So this is an example of incomplete fat suppression artifact, which you can see only on the fat suppressed sequences. You can see the signal abnormality. You see kind of band-like areas of really bright signal in the orbit on these fat suppressed sequences, which is the T2 fat sat and the T1 post-contrast fat sat, but you don't see any abnormal soft tissue on the T1 weighted images. And on the coronal images, often, which may or may not be included, your axials may or may not go down through the maxilla, but often on a coronal or even on a scout image, you might be able to see dental amalgam. And that should give you a clue that you're dealing with artifact. Sometimes it can be really hard to tell, but always look back at your T1 pre-contrast images. So this is another patient with incomplete fat suppression artifact. You can see here on the axial fat sat post-contrast images. Again, apparent enhancement throughout the intraconal and extraconal orbit, as well as enhancement of the anterior chamber of the orbit and a distorted globe. But here on the axial T1 weighted and T2 weighted non-fat suppressed images through the level of the lens, you can see this little focal susceptibility artifact in the anterior chamber. And this is actually a keratoprosthesis, which I'll show in the next plane on the next slide. And there's no abnormal soft tissue in the intraconal or extraconal fat on the T1 or non-fat suppressed T2 weighted images. So this is another example of incomplete fat suppression artifact. So spectral fat saturation or FAT-SAT techniques takes advantage of the fact that water and fat protons resonate at slightly different frequencies in a magnetic field. And it's a great technique, but it can be prone to artifact due to ferromagnetic substances, as in this keratoprosthesis in the prior patient, which is a treatment for corneal disease. It's also prone to artifact at the bone-air interface due to differing magnetic susceptibility between the tissues. So both of these instances lead to a change in the specific resonance frequency of fat in localized areas, and that distorts the homogeneity of the magnetic field and leads to incomplete fat suppression. So in addition to sort of the pseudo lesion, the incomplete fat suppression artifact, certainly these other entities can present as an infiltrative orbital mass. So we're going to go just show you some of those examples. So this is a patient with orbital lymphoma, and it has a really variable presentation. You can see just isolated enlargement of the lacrimal gland, or enhancement along the optic nerve, or focal soft tissue in the preseptal soft tissues or conjunctiva. But it can also present as a transspatial infiltrative orbital mass, as in this case, where you can see transspatial enhancing infiltrative soft tissue in the right orbit. It's fairly homogeneously enhancing. You can definitely see that that abnormality is confirmed on your T1 weighted images. And it's hypointense on T2, compatible with a hypercellular tumor, which these lymphomas are. And because it's hypercellular, it can also demonstrate restricted diffusion. So it can be bright on diffusion and relatively low on ADC sequences. So this is a pretty characteristic case of orbital lymphoma, but that can also look almost identical to idiopathic orbital inflammation, which we'll show in another case. This is a case of orbital cellulitis, an HIV patient with optic neuritis due to toxoplasmosis. And you can see there's both preseptal and postseptal involvement and sort of transspatial enhancement. But you can see that there's confirmation of the abnormality on the T1 weighted pre-contrast images. Patients really, these patients typically present acutely with pain, swelling, fever, and vision loss. And the etiology can be bacterial, can be from overlying or cutaneous or sinus infections, but it can be fungal or atypical if they're immunocompromised, as in this case of orbital cellulitis due to toxoplasmosis. So I alluded to this earlier, orbital pseudotumor, or the now called idiopathic orbital inflammation. It can be non-specific, as in we don't have an underlying etiology or diagnosis, or it can be specific orbital inflammation due to an underlying systemic disease such as Sjogren's syndrome or lupus, usually an underlying autoimmune disease. These can present as isolated extraocular muscle inflammation or as a diffuse transfacial infiltrative mass, as in this case. And the varied imaging appearance often mimics neoplasm or infection and often requires tissue sampling. So this is orbital pseudotumor again, this enhancing transfacial infiltrative mass confirmed on the T1 weighted pre-contrast images with abnormal soft tissue in the intraconal muscles as well, intraconal orbit, as well as involving the extraocular muscles, and relatively low on T2 weighted images. And then finally, also when you're differential of an infiltrative orbital mass as orbital metastasis, it's not super common to be, transfacial like this, but it can happen, especially in the setting of breast cancer. Particularly if the patient has an infiltrative orbital mass, again, you can see how it's confirmed on the T1 weighted pre-contrast images, this sort of retrobulbar infiltrative mass. But they also have involvement of the extraocular muscles in the contralateral orbit. But you can see in this particular patient with an infiltrative orbital mass, and they also have enophthalmos, you can see that the globe on the left is relatively displaced posteriorly or within the socket, if you will. The globe is sort of posteriorly displaced compared to the contralateral side. This is compatible with enophthalmos, and this is breast cancer, metastatic disease, until proven otherwise. This is a very common appearance due to the serous and fibrotic changes that occurs with some breast cancer orbital mass metastasis. It has a tendency to cause fibrosis and anophthalmos. Okay, so overall teaching points in this case: first, always confirm any abnormalities on your fat saturated imaging with your non-fat suppressed images, as poor fat suppression can mimic an infiltrative orbital mass. And then secondly, a tissue diagnosis may be necessary in the setting of a truly infiltrative orbital mass to exclude neoplasms such as lymphoma or rarely metastasis. And certainly if you see anophthalmos, think about breast cancer. Okay, let's move on to case two. Hopefully I'll be able to do this without screen share, stopping my share. So this is a 55-year-old with nasal stuffiness and rhinorrhea. Rhinorrhea meaning some drainage from the nose. Okay, let's see if this works. Yay. Okay. So here's our first images. So they started with the CT of the sinuses. And here on the axial CT images, you can see this sort of polypoid soft tissue in the nasal cavity bilaterally. It comes all the way back to the choana, or the opening to the nasopharynx. It's medial to the turbinates and comes up into the superior nasal cavity in an area known as the sphenoethmoidal recess, and sort of fills and widens the sphenoethmoidal recess. And then this polypoid soft tissue just completely fills the or almost completely fills the sphenoid sinuses, a little bit more on the right than the left. There's some scattered areas of calcification, but it's very polypoid and mass-like and sort of expansile in these locations. And then there's a little bit of soft tissue in the adjacent posterior ethmoids as well. In every sinus CT, you always, especially if stuff comes all the way to the skull base, you definitely want to look in your coronal plane and your sagittal plane to look at the integrity of the skull base. And here on the coronals, you can actually see that there's dehiscence of the adjacent skull base, kind of bilaterally, involving that posterior ethmoid roof and sort of anterior planum sphenoidale. You can see these bilateral areas of dehiscence, a little bit more on the right compared to the left. Actually, it's pretty bilateral. And then you can kind of see that again in the sagittal plane, sort of the planum sphenoidale and the posterior ethmoid roof are pretty widely dehiscent. So that's the bone windows on the sinus. Remember, every single sinus CT you should also reconstruct in a soft tissue algorithm. And I can't emphasize that enough. You want to look at your soft tissue windows, always look at your soft tissues around your sinuses, but also look at your brain on every single CT of the sinuses. And then on your soft tissue windows, some of this stuff is not really very low density. It's kind of intermediate in density. And then when you come up to your brain, there's some low attenuation coming from the, or involving, coming all the way up to the inferior aspect of the left lateral ventricle, a little bit of asymmetry in the lateral ventricles. So this hypoattenuation may be encephalomalacia, not sure, coming all the way down to this abnormality. And then because we saw soft tissue that wasn't normal, just run-of-the-mill low density polyps, and we're questioning this soft tissue abnormality in the brain, an MRI was recommended. And on MRI, you can see there's definite sort of tethering and inferior herniation of brain parenchyma through that bony defect into the sphenoid sinus and sort of extending into the posterior ethmoids as well. So you have both soft tissue and fluid sort of signal extending through those bony defects. And then there's sort of gliosis and encephalomalacia with some volume loss in the left greater than right inferior frontal lobes. And you can see this abnormal soft tissue is sort of isodense to brain parenchyma, or sorry, isointense on all of the sequences. Here's a T2. And again, you can see this sort of soft tissue that's sort of tethered and inferiorly displaced on both of these, with also CSF signal soft tissue extending into the sphenoids and posterior ethmoids. So this is a very unusual case, but it is a case that is compatible with bilateral large meningoencephalocele with adjacent traction gliosis of the brain parenchyma. Some of these, when they're long-standing, can calcify. So not something that you would want to blow off as just routine run-of-the-mill sinonasal polyposis. Whoops. So again, to review the salient imaging findings, again, we have non-dependent polypoid soft tissue in the superior nasal cavity with adjacent bony defects of the skull base involving the planus sphenoidale and posterior ethmoid roof bilaterally. Gosh, I keep going the wrong way. I'm going to do this now. And then on the soft tissue windows, you can see gliosis and hypodensity with encephalomalacia in the inferior frontal lobe. And then on MR, you can see inferior herniation of gliotic brain and CSF through the defects into the superior nasal cavity and sphenoid sinuses. So here's my poll question this time. So we decided we think this is bilateral meningoencephalocele. So what's the next step in managing the patient? Is it biopsy, angiogram, beta-2 transferrin assay of the rhinorrhea, or antibiotics and steroids? So let's go ahead and answer. I'll give you another 5 seconds or so. And let's see the results. Okay, so most of you are saying beta-2 transferrin assay. A couple people are wondering if we should do an angiogram. But the correct answer is a beta-2 transferrin assay of the rhinorrhea. And we're going to talk about that. So this is a patient with rhinorrhea, runny nose, and a skull base defect who is actually experiencing a CSF leak due to the meningoencephalocele. So these patients typically present with unilateral, clear, watery rhinorrhea that worsens with Valsalva or leaning over. And this really absolutely must be worked up and surgically repaired and treated because there is a 50% risk of meningitis if these are left alone. So the clinical diagnosis of a CSF leak at the skull base is confirmed with taking a little bit of the fluid. It just requires a couple drops, putting it, collecting, the patient collects it in a test tube and sends it off for beta-2 transferrin assay. Beta-2 transferrin is a protein that is very specific to the CSF. And its presence confirms the leak. It's a very sensitive and specific test. And again, it only takes a couple drops. So then after we confirm the presence of a leak, and I usually dictate if I'm suspecting a meningocele in my report that would correlate with beta-2 transferrin testing of the rhinorrhea. If that testing is positive, then the clinician is, the next step is to localize the leak, and the surgeon wants to define the size of the leak so that they are prepared for their surgical repair, which is typically done endoscopically. So the first, the initial study, the first line study for working up a suspected skull base CSF leak is a thin non-contrast CT through the sinuses and mastoids. If we only see one skull base defect and potential site of a leak, then the patient can go on for endoscopic sinus surgery or otologic surgery to repair the site of the leak. If there are multiple bony defects, then that patient may require cisternography, either CT cisternogram or new MR cisternogram techniques with heavily T2 weighted images to try to attempt to determine the site of an active leak. And then finally, if there's polypoid soft tissue, non-dependent next to a bony defect along the skull base and a meningoencephalocele suspected, an MRI should be obtained to confirm its presence. The surgeons want to know if that exists preoperatively. So meningoencephaloceles can be congenital or acquired. We can see them after trauma, but they can also occur spontaneously. And we're seeing them much, much more frequently, particularly in the United States, as we are kind of encountering an obesity epidemic in the setting of idiopathic intracranial hypertension. So they should be suspected anytime you see non-dependent polypoid soft tissue in the superior nasal cavity with an adjacent bony defect. And it's really imperative to look very carefully in any patient with some polypoid soft tissue in the superior nasal cavity for the adjacent dehiscent bone. You also want to look carefully in the brain windows for any gliosis. And if a bony defect is seen adjacent to polypoid soft tissue mass, the referring physician should correlate for the presence of a CSF leak that is rhinorrhea that worsens with Valsalva or bending over, and consider an MRI to confirm the presence and define the extent of the meningocele. You definitely don't want to rush in to biopsy something if you think it could be a meningocele. But due to the risk of meningitis, almost all of these, essentially all of these should be worked up and repaired surgically. So an MRI will confirm the diagnosis. We do we'll do T1 and T2 weighted images, but typically we'll do heavily T2 weighted images in multiple planes. The KISS, Fiesta, or SPACE sequences, depending on your type of MRI. And in these settings, we're going to look for frank herniation of brain parenchyma. Sometimes it's a little T2 hyperintense because it's gliotic. Look for tethering of the adjacent brain parenchyma, gliosis, or a column of CSF in the setting of just a meningocele alone. These can be sometimes really difficult, and you want to make sure you're doing really thin imaging to look for these meningoceles. So just moving on to differential diagnosis of sort of bilateral polypoid nasal cavity mass. In general, meningoceles, it's pretty rare to be bilateral and big like this, but sometimes you can have that bilaterally along the olfactory cleft in the anterior and superior nasal cavity. Sinonasal polyposis is much more frequently seen superiorly and bilaterally. And then we would think about the possibility of a sinonasal malignancy like esthesioneuroblastoma. So I'm going to go through some of these and talk about why this case is not that. So sinonasal polyposis, we see that really commonly in the nasal cavity, and it's often in the superior nasal cavity also. It's associated with allergic rhinitis and asthma. It's an underlying sort of systemic disease. And as in all of these cases, you often see multifocal and bilateral disease, often in the superior nasal cavity and olfactory recess, as in these cases. It's usually in an anterior greater than posterior distribution. And you often see polypoid mucosal thickening extending into the lateral nasal cavity and into the sinuses as well. You can often see remodeling, sometimes thinning, and even bony dehiscence of the adjacent bones. You shouldn't see frank destruction of bone. And on soft tissue windows, the polyposis is usually mucoid density, not intermediate in density, as in our index case that I showed earlier. You can sometimes get areas of inspissated and complex secretions, and I'll show an example. But in our case, the polyposis was more prominent posteriorly, and review of the brain and soft tissue windows was the most helpful in determining that we weren't dealing with simple polyposis. Due to occasional inspissated secretions on T1 weighted images, you can often see variable areas of low and high signal, as in this case. But so you can see areas of a little bit of low signal, but on T2 weighted images, benign polyposis should be predominantly very T2 hyperintense and very watery. And non-enhancing centrally, maybe thin peripheral enhancement of the inflamed mucosa. Esthesioneuroblastoma is a malignant neuroectodermal tumor affecting the olfactory neuroepithelium, and as such, most often presents clinically with anosmia, the lack of ability to smell, loss of the ability to smell, and nasal obstruction, and can present as a dumbbell-shaped mass that's centered along the anterior cranial fossa. It's often bilateral, as in this case, but here you can see bony destruction. So the bones are just completely blown through, even the crista galli. Both of the cribriform plates, lateral lamella and crista galli, are sort of blown through in this setting. As in other malignancies, you want to look and review the soft tissue windows on CT, and you want to look for extra sinus extension into the adjacent anterior cranial fossa. Which if I windowed this down, you might see abnormal soft tissue there. That's going to confirm that it's more of an aggressive process. If you ever think that you're dealing with something that is not benign, simple polyposis, or you're not sure, always get an MRI. That's one of my big teaching points. And here on MRI, you can see that the mass is sort of characteristically T2 hypointense. You can see it's sort of dumbbell shaped. It's in the superior nasal cavity, but also extending intracranially. It's very avidly centrally enhancing. Polyps should never centrally enhance like this. and it's extending intracranially. And you can see one of the hallmarks that would help us suggest esthesioneuroblastoma in the differential over any other aggressive malignancy, sinonasal malignancy, is it has a tendency to have these adjacent intracranial cysts. You can see this T2 hyperintense sort of peripherally enhancing cyst on the within the parenchyma adjacent to this mass, and that's fairly characteristic for esthesia. So this is a sinonasal malignancy. So this is a helpful algorithm for the approach to a polypoid nasal mass if you discover it on a CT of the sinuses. First, you want to review the bone windows and determine if you think that it's benign bony remodeling or not. If it is benign remodeling, meaning it's expansile, kind of pushing on the bone, then you want to look at your soft tissue windows. If you see increased density within the soft tissues, any calcification, if it's a post-contrast image, any enhancement, focal sclerosis, that should be a red flag that you're not dealing with normal run-of-the-mill polyposis, and you could be dealing with a benign or low-grade neoplasm because it's causing bony remodeling, and you should consider a biopsy. If it's just remodeling and it's hypodense and you on the soft tissue windows, you don't see any extra sinus soft tissue, it's probably polyposis and no need for an MRI. Alternatively, if you see bony destruction, as in the esthesioneuroblastoma case that we saw, look on your soft tissue windows next for extra sinus soft tissue and consider the possibility of a sinonasal malignancy and recommend MRI and tissue sampling. And then finally, as in our index case, if you see a polypoid nasal mass with adjacent bony dehiscence of the skull base, look on your soft tissue windows for any gliosis in the adjacent brain and consider the possibility of meningocele and recommend beta-2 transferrin and MRI. So that's my little Pearl algorithm for a polypoid nasal mass. Okay, let's move on to the next case. Case number 3 is a 24-year-old male with conductive hearing loss, left greater than right. And I'm going to pull up the images. So here's his left temporal bone. So they got temporal bone CT to kind of work up this conductive hearing loss. And here on the temporal bone CT, I'm sort of going to scroll a little bit. We can see our external auditory canal. Tympanic membrane is normal. And actually, one thing I didn't tell you is that this patient's, you dove in the chart and you saw that the otoscopy was normal, meaning that middle ear exam on when they looked in the ear looked normal. And we can kind of confirm that. The eardrum looks normal, the external auditory canal looks normal, the middle ear is clear, the mastoid air cells are clear, with the exception of a tiny little cell, but pretty normal looking temporal bone in general. So, but remember, they have a conductive hearing loss. And we're going to look at the ossicles. They look pretty normal. And we're going to follow the, this is the malleus anteriorly to the left of my crosshair. Then we have the incus posteriorly. We have the ice cream cone. And the long process of the incus coming down to articulate with the stapes. And then we're following the anterior and posterior crus of the stapes down to the oval window. And here, just anterior to the oval window, I'm starting to see this little area of lucency in this otherwise supposed to be dense otic capsule. So there's a little lucency there. And that is not a normal structure. And so now let's go to the other side and look on and the patient had a bilateral hearing loss, but it was worse on the left. And maybe you can see here that there's a little tiny lucency in that same little location, right between the vestibule and the cochlea, a little subtle lucency in the bone that's otherwise very dense all around the inner ear structures. So again, coming down just anterior to the, this is the oval window here, just anterior to the oval window is this little area of lucency. And so those are the imaging findings. Let's go back to our PowerPoint. And again, I forgot to show you that his otoscopic exam was normal. So here's the salient imaging findings. Again, here we have a right and left temporal bone. And on both of those images, you can see that subtle lucency in the left greater than right otic capsule, just anterior to the oval window. So here's your poll question. What's the diagnosis in this case? Is it tympanosclerosis fenestral otosclerosis, cholesteatoma, or congenital ossicular fixation? Give you a couple of minutes here, or I guess seconds. All right, go ahead and put your votes in. And then let's go ahead and close the poll. All right, so most of you selected fenestral otosclerosis. Very good. And actually, that is what this is a case of. This is a case of fenestral otosclerosis. Oops. So just a reminder about conductive hearing loss in general. Remember that can occur as a result of anything that blocks the conduction of sound as it goes from the sound waves as they go from the external ear through the external auditory canal to the tympanic membrane. It vibrates the tympanic membrane and then vibrates the ossicles, which amplifies, each ossicle amplifies the sound wave. And then going all the way to the stapes, which then attaches to the foot plate of the stapes attaches to the oval window, which then causes vibrations into the inner ear. So conductive hearing loss is sound wave conduction that's blocked anywhere from the external ear to the level of the oval window. And our role, they can usually see external auditory canal or TM pathology. They want us to talk about the middle ear, the ossicles, and the oval window in the setting of conductive hearing loss. So again, here's our case, fenestral otosclerosis, very subtle lucency in the dense otic capsule between the vestibule and the cochlea. Here is how dense that bone should be. It should be just isodense to the rest of the bone all around the inner ear. This is some of the densest bone in the body, and it's actually even preserved even in the setting of pretty severe osteoporosis. If you go and start looking at this, you can see there can be osteopenia throughout the rest of the skull base, but relative preservation of the bone around the otic capsule. It's really dense bone. So any lucency there should be considered abnormal. And so this region, this classic lucency, is known, that spot right between the vestibule and the cochlea, it has a fancy name that sometimes shows up in a boards type situation, and it's called the fistula antifenestrum, which I think translates to something like cleft anterior to the window, in front of the window. And so this is just the classic location for that lucency that we see in fenestral otosclerosis. And this entity is a systemic process and typically bilateral, but the otoscopy exam should be normal in this setting. So again, fenestral otosclerosis, the pathology is the spongy bone formation, happens in the bony labyrinth that starts first and worst at that fistula antifenestrum, anterior to the oval window, and that causes fixation and fusion of the stapes foot plate. And then once you fuse that foot plate, that it can no longer vibrate, that leading to a significant conductive hearing loss. And as mentioned, it's often bilateral and progressive. It's fixed surgically by resecting the stapes or doing a stapedectomy, and placement of a prosthesis or a little piston is stuck onto the incus, and then they sort of fracture the foot plate and they put this piston in to repair the fixed stapes. And this is a case from StatDX. Later in the stage of disease, the patient can progress to cochlear otosclerosis, which can be seen in imaging as a characteristic halo of lucency around the cochlea, and sometimes even goes back to around the vestibule and semicircular canals, but it typically progresses anteriorly around the cochlea first. This halo of lucency around the cochlea is essentially an Aunt Minnie diagnosis, very characteristic appearance. There's only two other things that can go in the differential, and that is Paget's disease in a very elderly patient. You could consider Paget's in the differential, as well as cochlear otosclerosis, or in a young patient, in an infant, you could consider osteogenesis imperfecta. Those are the only two other entities that can cause that sort of halo of lucency around the cochlea. Otherwise, it's cochlear otosclerosis. So one of the most, moving on to another cause of conductive hearing loss, cholesteatoma is actually probably one of the most common causes, other than just chronic otitis media. Cholesteatoma is sort of the end stage of chronic otitis media and chronic eustachian tube dysfunction, where patients have an inability to equalize the pressure between atmosphere and their middle ear cavity. And that leads to chronic negative pressure, which causes retraction or sucking in of the eardrum. And then these patients can develop retraction pockets that ultimately kind of accumulate keratinized debris and sort of dead skin cells. And it classically starts, these acquired cholesteatomas typically start in the lateral epitympanic recess, or a place known as Prusac space, in the sort of superior aspect of the tympanic membrane, because that's the pars flaccida portion that doesn't have as much collagen in the eardrum. And so again, the hallmark of this diagnosis on imaging is if you see a middle ear mass, particularly if it's centered in that location in the epitympanum or Prusac space, with bony erosion. You kind of have to have both the presence of a middle ear soft tissue mass with bony erosion of whatever adjacent bones are nearby, as in the ossicles in this case, to call a cholesteatoma. If you just have abnormal soft tissue, sometimes that can be granulation tissue or other entities. But once you get bone erosion and soft tissue in the setting of chronic otitis media, that's cholesteatoma until proven otherwise. So on otoscopy, it shouldn't be normal typically in the setting of cholesteatoma. They're usually going to at least see retraction of the tympanic membrane, and often they can see these little retraction pockets form in the superior aspect. This is that epitympanum. Sometimes and you can see sort of keratinized, sort of pearly white epithelium, and you can see a tympanic membrane perforation in this setting. Sometimes you have perforation, sometimes you don't in these patients. So here's another case of cholesteatoma. Here you can see this is pretty large cholesteatoma. Soft tissue mass is sort of encasing and eroding the ossicles and the tegmen. But what you can, so this is in the epitympanum. Remember the middle ear cavity is divided into the mesotympanum, which is at the level of the external auditory canal, the epitympanum, which is superiorly, and a hypotympanum, which is inferiorly. Here in the epitympanum, you can see erosion of the tegmen tympani and the ossicles. Here in the on this image, you can see that there's blunting of the scutum. Here's the normal triangular, very sharp appearance of the scutum on the normal contralateral side, as well as the normal ossicles in the epitympanum, the malleus, which then articulates at the incus. And here you can see how those ossicles are eroded and the scutum is completely blunted. So this is a large cholesteatoma in the epitympanum with blunting of the scutum. Another potential source of conductive hearing loss in the setting of a normal otoscopic exam is ossicular fixation. So in comparison to otosclerosis, in which the hearing loss is progressive over time, these patients have a congenital long-standing conductive hearing loss due to fixation of the ossicles. And they're most commonly bony or fibrous fusion at the ligamentous attachments with the middle ear walls. The most common sites are at the stapes foot plate, which is really difficult to see on imaging. But the other second most common place where we can make a difference and see this on imaging is the malleolar head, as in this case. So here you can see that the ossicle doesn't look totally normal. It's sort of angulated and thickened, and there's bony fusion with the roof of the middle ear cavity. So bony or fibrous fusion at the ligamentous attachments is what we're looking for in these patients with ossicular fixation. So it's really important when you look at all of your temporal bone CTs to kind of get used to looking at air. You want to see air all around your ossicles. So here you don't see air around the malleolar head. And so this, especially in patients with conductive hearing loss, this is compatible with ossicular fixation. So another potential source of conductive hearing loss is called as an entity known as tympanosclerosis, in which there's diffuse calcified soft tissue throughout the middle ear. It's usually a result of long-standing chronic otitis media, but it can also happen in the setting of surgery or trauma. And as in this case, here's a patient with chronic otitis media. You can see there's sort of a sclerotic, underpneumatized mastoid with soft tissue in the middle ear and in the mastoid air cells. You can see it's non-dependent soft tissue. But what you can also see is focal calcific densities throughout the middle ear, along the ossicles, and at the attachment sites for the ligaments. And so that causes a pretty severe conductive hearing loss. So in this setting, otoscopy is usually abnormal, and the surgeons or the ENTs will often see this sort of thickening and plaque-like thickening of the tympanic membrane densely calcified, and that also can contribute to the conductive hearing loss as well. So in summary, for this case, the findings of conductive hearing loss on temporal bone CT can be subtle, and knowing the findings on otoscopy can be helpful. Conductive hearing loss with normal otoscopic exam can be seen in the setting of otosclerosis, congenital ossicular fixation, and other congenital causes. I didn't go into some of these are really rare, over window atresia, etc. And you want to look carefully at all of your ossicles, ligaments, oval window, and visually antifenestrine bilaterally, and get used to looking at these structures on every T-bone CT. Okay, so moving on to case number 4. So a 61-year-old female who had a history of aneurysms, clipped in the past. She came into the ER with headaches and right-sided whooshing, and a CTA was ordered to assess for aneurysm. And just so you know, she did have an additional history. The ENT did ultimately look in her ear after we looked at the CTA, and she has a cherry red mass within her middle ear. So we're going to go to the images now. And here you can see on her CTA, here's the carotid artery, and it looks pretty normal. But if you're going really fast and you're not really looking at the ear, you would probably miss this small to the left of my crosshairs. You can see this abnormal soft tissue in the inferior aspect of the middle ear cavity. Compare it to the other side. There's abnormal soft tissue in that hypotympanum. And it's pretty avidly enhancing, actually. So abnormal soft tissue in the hypotympanum to the left. And here on the coronals, these are pretty thick reformats, kind of hard to see on here, but I'll show you on the other reformatted images. You can see here in this hypotympanum, there's this abnormal soft tissue. Over here, you really don't see that. Again, these are pretty MIPT because these are the coronal MIPT reformats, but there's abnormal soft tissue in there. And we noticed that. We recommended they look in the ear, and they did, and they saw this cherry red mass. And then here, we also then recommended a temporal bone CT. And on these thin section temporal bone CT windows images, here you can kind of make out on the right in the hypotympanum, we're a little angled on this patient, but compared to over here, you see abnormal soft tissue. And then maybe you can kind of make out, but this bone doesn't look entirely normal. Look how dense and white this bone is on the other side. And there's sort of a permeative bony erosion here coming down from the hypotympanum and coming down towards the jugular foramen. Okay, so those are the images. Let's go back to our PowerPoint and we'll go over. So again, salient imaging findings, mass in the hypotympanum that on both the axial and coronal images, that's avidly enhancing but distinct from the carotid artery. And then on the bone windows, you can see this sort of permeative bony erosion of the adjacent mastoid. So here's our poll question. What's the diagnosis in this patient with pulsatile tinnitus and a middle ear mass? Is it glomus tympanicum, an aberrant or lateralized carotid artery, cholesteatoma, or a dehiscent jugular bulb? So go ahead and put your vote. What do you think is going on in this particular patient? Okay, let's go ahead and close the panel. Okay, so we're sort of split. Some people think maybe it's a jugular bulb, and some think it might be a glomus tympanicum. And this actually is a case of a glomus tympanicum tumor. So let's talk about that. So glomus tympanicum tumors are paragangliomas. It's another name for a paraganglioma that arises from the paraganglia from Jacobson's nerve, which is the tympanic branch of cranial nerve 9. Interestingly, this is one of those nerves that's responsible for referred otalgia or ear pain in the setting of a pharyngeal infection or tumor. So you can have tonsillitis or tonsillar tumor that causes ear pain, and that's called referred otalgia, and that's because of this tympanic branch of the glossopharyngeal nerve or cranial nerve 9. At any rate, these paraganglia are located in the middle ear mucosa over the cochlear promontory and extend down towards the jugular foramen. And the bone over the cochlear promontory is another name for that dense bone over the basal turn of the cochlea within the sort of meso and hypotympanum of the middle ear. And so these, because it's at the level of the EAC, when you see these little lesions, they're very hypervascular and they can be seen on exam as a cherry red mass in the middle ear. And because they're hypervascular, they can typically present with pulsatile tinnitus once they get big enough. When they're small, they're located over the cochlear promontory, but when they're big, they follow the location of the paraganglia and extend from the cochlear promontory into the hypotympanum and through the so-called floor of the middle ear cavity, and vice versa, tympanicum tumors. So tympanicum tumors extend down towards the jugular foramen, and jugulary tumors can extend up through the floor of the middle ear cavity to overlie the cochlear promontory. And these are so-called jugulotympanicum tumors. Sometimes you can't tell where the chicken and the egg where it started, if it started from as a tympanicum tumor and came down, or a jugulary tumor and came up, but they both extend up and down. So the imaging features of a glomus tympanicum or a jugulotympanicum are similar to paragangliomas anywhere else in the body. They're very hypervascular, and as such, they hyperenhance. And they have flow voids on both T1 and T2 weighted images, the so-called pepper. And then because of the intermittent flow, they can have areas of intrinsic T1 hyperintensity, so-called SALT. So you'll hear people talk about salt and pepper appearance, as well as hyperenhancement. And then finally, they have that permeative bony erosion on CT around the margins of the lesion. It's not nice and scalloped and well circumscribed. It's sort of irregular around the periphery of these lesions. So moving on to another etiology for a cherry red mass behind the eardrum on exam that causes pulsatile tinnitus is a lateralized internal carotid artery. This is a really rare variant in which the ICA extends to the skull base lateral to the cochlear promontory. It passes through the anterior middle ear in the mesotympanum at the level of the external auditory canal. And it can be associated with really thin or dehiscent overlying bone. And it should be noted in a preoperative patient, because this could be at risk if the patient even goes in and they put tubes in. Usually they put tubes in the anterior and inferior quadrant of the tympanic membrane. And so that could be pretty disastrous complication if they get into the carotid. So important to note a lateralized internal carotid artery, but typically this is associated with a normal foramen spinosum. But can present as a retrotympanic vascular mass, and also can present if there's thin dehiscent bone with pulsatile tinnitus. So an aberrant ICA is actually, it sounds the same, but it's a little bit different. It's an even rarer congenital variant in which the carotid takes an anomalous course. Again, seen lateral to the basal turn of the cochlea. You can see it comes out lateral to that. But instead of going anteriorly into the mesotympanum, it sort of comes from anterior to posterior in the middle ear, and is found in the posterior hypotympanum, associated with the large, what they call inferior tympanic canaliculus, which is sort of this sort of S-shaped course that it takes. And then it's often associated with an area of stenosis at its connection with the normal location of the ICA and sort of wasting there. And this is an aberrant ICA. It can sometimes be associated with an entity known as a persistent stapedial artery. And if that's the case, it usually is associated with an absent foramen spinosum. This particular one has a foramen spinosum, but it's just another variant of the carotid in the ear, and certainly very important to mention to a potential patient undergoing otologic surgery, and also could be a source of pulsatile tinnitus, as well as a cherry red vascular mass. So something to look for. So how do we identify an anomalous course of the carotid and the temporal bone? Well, I go to the axial images to the level of the basal turn of the cochlea. This is the inferiormost aspect of the cochlea. So I'm going from bottom up, and I find this biggest turn. It's called the basal turn of the cochlea. And then at that level, I draw a line perpendicular to the basal turn of the cochlea. And if the carotid is lateral to that line, then it's aberrant or lateralized. And again, it's probably not that important to specify which is which. That's sort of nuanced, but if it's lateral to that line, you do want to mention it that it is either aberrant or lateralized, because that's very important from a surgical perspective. And this is the normal side, and you can see that this is medial to that line, does not cross past it. So that's a normal location of the internal carotid artery. So really important in every patient or in a patient with pulsatile tinnitus to mention that. Okay, so quickly, cholesteatoma can be a source of pulsatile tinnitus and middle ear mass. We've already sort of talked about this, but again, it should be sort of more pearly white on endoscopy. Often the superior epitympanum, not usually the mesotympanum or hypotympanum, is a red mass. So that's one way to differentiate, but also, it looks different than any of these other entities that we've described. It's not vascular mass. And then finally, one other lesion that can cause a red mass behind the eardrum, the one that you guys were thinking about, it also causes pulsatile tinnitus. And that's a high riding or dehiscent jugular bulb that is with or without a diverticulum, as in this case. So what you should see when you're at the level of the basal turn of the cochlea, if you see a jugular bulb still at that location, then it is a high riding, somewhat abnormal jugular bulb. And then certainly if you want to look for any overlying bony dehiscence or pooching out diverticulum, as in this case, this can certainly be an etiology of a pulsatile tinnitus. Here's the normal side jugular bulb. And this can certainly also cause a red vascular mass when you look into the ear. And so you want to make sure that whatever lesion you're looking at is not contiguous with the jugular foramen. And you also then want to look at the bony margins. If it's clean margins and not a permeative appearance, it's most likely a venous diverticulum. Or if it's a permeative bony erosion around that lesion, then you might suggest the possibility of a glomus tumor. So those are the kind of things that can help you differentiate, and certainly MR can help as well. And so again, trying to determine if you're dealing with a high riding jugular bulb or an aberrant carotid, always go to the basal turn of the cochlea, which is the lowermost portion of the cochlea. Here we actually still see the jugular bulb. You shouldn't at this level. And so that's a high riding jugular bulb. But also this same patient actually has a lateralized ICA, because you can see the carotid is a little lateral to that line. So this patient has both vascular anomalies and certainly at least two different potential etiologies for pulsatile tinnitus, as well as some thinning of the overlying bone there. Okay, so just briefly want to summarize talking about pulsatile tinnitus. This is tinnitus that varies with the heartbeat. It's different than the continuous sort of high-pitched buzzing tinnitus that's associated with sensorineural hearing loss. It's seen in less than 10% of tinnitus patients, so it's not that common. But when we see it, there should be very high yield. We should be able to see an abnormality on these patients. In over 70% of cases, it's usually a vascular etiology. And then if a patient has objective pulsatile tinnitus, that is the referring otologist puts a stethoscope around the ear. If there's an audible bruit, then we absolutely have to find an etiology there. We should see an etiology in 100% of cases. So if you don't, you want to keep looking because that is absolutely pathologic. So what are some of the causes? We talked about some of these venous causes. Most common high riding dehiscent jugular bulb, sigmoid sinus diverticulum, or jugular bulb diverticula. Dural AV fistulas can occur from chronic stenosis of the sigmoid sinus. You can get sort of recruitment of ECA branches, usually the occipital arteries, and that can cause increased vascularity around the ear, and that can cause pulsatile tinnitus. And sometimes you can't see that unless you have dynamic imaging to see sort of shunting into the venous system on the earlier arterial phase. However, a lot of times you can see sort of secondary features from big occipital artery, kind of ECA feeders on that side, but that's harder to see. Arterial causes, aneurysm, lateral, we talked about aberrant or lateralized ICA. Remember, dissections, carotid dissections, or even high-grade stenosis can cause pulsatile tinnitus, and of course FMD, fibromuscular dysplasia. We can see otologic causes. We already mentioned cholesteatoma, but other things that otosclerosis actually has been associated with pulsatile tinnitus, as well as semicircular canal dehiscence. We talked about glomus tympanicum tumors. And then finally, idiopathic intracranial hypertension, particularly in obese patients, is also associated with pulsatile tinnitus. So the diagnosis, if typically confirmed with an ENT evaluation, they look in the ear for hypervascular or other middle ear mass. They can do flow altering maneuvers. They can see if the pulsatile tinnitus is extinguishable with venous compression, and then think that it's more of a venous etiology. The best initial study for diagnosis, in my opinion, is a hybrid CTA-CTV of the head and neck with temporal bone reformats. We do a hybrid timing of a 25 to 35 second delay extending from the carotid bifurcation through the vertex. And this is going to see pretty much the majority of the pathology that we mentioned on the prior slide, with the exception of maybe a dural AV fistula. Even you can see secondary features of intracranial hypertension with a large expanded empty sella and remodeling the skull base. But in general, dural AV fistula you might not catch on a CTA-CTV because it's non-dynamic, but pretty much any of these other things, if you do a hybrid CTA-CTV with T-bone reformats, you should be able to see the etiology. So that's usually the first line test, in my opinion. Sometimes MRI can be helpful if you're working up IIH, idiopathic hypertension, or brainstem pathology. And then digital subtraction angiography is helpful in dural AV fistula. And these can also be time-resolved MRA is often also helpful in that setting. So in summary, most cases of pulsatile tinnitus are vascular, and the initial study with the highest yield is a combined CTA-CTV protocol with T-bone reformats. And I think I'm going to stop here. I had a few more cases, but I think we're over time. So I want to open up some time for questions if anyone has any questions. Okay, first one. What's the difference between bony dehiscence versus bony destruction or erosion? Okay, very good question. It's very confusing at times. I'm going to try to go back and show a picture, and I think a picture is worth 1,000 words. So to me, dehiscence is something that takes a long time to develop. It's sort of adjacent to an expansile process. You get expansion and you get remodeling of the walls. And then over time, you get focal areas of dehiscence. To me, destruction, erosion is kind of the same thing as destruction. It's irregularly marginated. There's irregular it's not scalloped. It's sort of an infiltrative sort of appearance. But destruction, I'm going to go back to my esthesia neuroblastoma case. And I think that kind of elucidates it the best when you're talking about sort of erosion and destruction. So here you see where you can almost imagine where the bone was. So the bone has kind of stayed in its normal location, but it's just sort of blown through by soft tissue. Whereas on polyposis, in the setting of polyposis or meningitis, something that's been there for a long time, it has a tendency to sort of remodel or push before you get air bone thinning. Let's get back. I think you can see it here. You can see sort of stripping and remodeling of bone. It definitely, you don't see any more bone because this is a large meningocele that came down. But it's the bone is sort of pushed and remodeled. Let's go back to the first patient. I don't have the axial images on here, but the axial images, we could see remodeling of bone. Again, that is, if you have remodeling of bone plus bone loss, to me, that sort of is more bone dehiscence versus if the bone is just blown through and there's abnormal soft tissue replacing where the bone used to be, that is more of a sort of bone erosion and destruction. That's kind of the same thing to me. I hope that answered your question. It is a very confusing distinction, but important. And it kind of takes one of those things where you just need to look at kind of a lot of cases and get used to looking at those things. Hope that helped. Any other questions? All right, thank you so much. And I'm sorry about the interruptions.
Totally fine.
COVID, I think, these days, trying to work from home. So.
Indeed. All right, have a great night.
Thank you all.
Thanks.
Appreciate it. Bye-bye.